afternoon, and good evening, wherever you may be in the world. Welcome to this panel discussion, which is on the topic innovative models to support the future of healthcare in Africa, where we'll be sharing perspective on public-private partnership, innovative data collection mechanisms, as well as the financing of it. My name is Dr. Nick Mangeya. I'm the Country Medical Director at Roche, based in Johannesburg, South Africa, and also the African Genomics Program Partnerships Lead. Thank you for joining us. We hope we're going to have an engaging dialogue for the next 60 minutes. And this LinkedIn event is part of our Future Proofing Healthcare initiative, which aims to accelerate and support the future evolution of healthcare by tracking and measuring some progress we're making in terms of achieving sustainable, personalized, as well as more integrated and digital health systems. And then maybe for some of you who are joining us for the first time, and perhaps to give context to those who are familiar with the concept, I think it's important to understand why we're here today. And I think if I can summarize it, I think most of us are based in Africa and some of us around the world, but it's important to understand in Africa today, we acknowledge that the health systems are under increasing pressure as the population and life expectancy improves. We see the demand on the healthcare services increasing. And also we're seeing the rise in non-communicable diseases, which is doubling the burden on what we have already from communicable diseases. And I think these challenges, it's important to highlight that there are further ramifications when it comes to strengthening health systems and adopting evidence-based and cost-effective new innovative methods of achieving healthcare in Africa, particularly if you think about how across the region, healthcare systems are trying to understand how can they really strive to implement these ambitious universal coverage goals. I think maybe one thing that's useful to point out is if you look at the state of health, WHO Africa Health Report, there's really an emphasis on saying how can we essentially support countries in identifying policies and practices that can really help them to meet these commitments towards universal health coverage, as well as health-related targets within the sustainable development goals sort of context. And it's a bit obvious, but I think it's still important for us to mention that COVID-19 has really sort of demonstrated to us the fragility of the healthcare systems. But what it does more than that is it really underlines the importance of data-based analysis to understand what countries can do to recover, firstly, but secondly, be able to really draw a more detailed picture about the system gaps and best practices that can help us to be better prepared or as well as to perform. And then I think it sort of brings us to how this initiative was initiated last year in 2021. So we have the Future Proofing Healthcare initiative, which was then launched with the idea of saying, how can we facilitate these much needed policy discussions in applying available health data, whether be it inputs, be it outputs or outcomes when it comes to better understanding health systems in Africa. And I think within the context of the future-proofing healthcare, there was a white paper which was produced, which was really focused on examining policy priorities to achieve these goals. And what was found within the context of this was that public-private partnership collaborations are of highest priority when it comes to achieving the leapfrog we require in healthcare on the continent. And this is why today we're really focusing on this to say, how can we take a closer look at some of these public-private partnership to hear what we can learn from them, as well as to see, what can we export to other settings and achieve equal or even greater benefit there. So, and in thinking about how to bring this, to more healthcare stakeholders on the continent in order to benefit and share these practices, we thought this virtual medium will really give us the best coverage and hopefully allow for a very meaningful dialogue and share these learnings, whether you attend to it live now or maybe you listen to this over and over after this session. And I want to come back to today now and just zone in to say we've got 3 experts with us today who will be sharing innovative financing models, including public-private partnerships, and looking at how we can aim to ensure that the African health systems are financed in a sustainable way to achieve our universal healthcare coverage by 2030. So we'll hear from Dr. Kanari, who is from Kenya, Dr. Agada Amande, who is from Nigeria, as well as Prof. Butayeb coming in from Morocco. And they'll really present concrete case studies here. And we want this discussion to explore these alternative funding models and to improve healthcare towards this goal. And then perhaps to you, the audience, thank you for coming. And I invite you to engage in the dialogue in the chat, which is on your right bottom. Please share your comments as the talks go on. But more importantly, also include your questions, which will field after the first part of the discussions when the speakers give a summary of their content. And then to kick it off, I'd like to invite and hand over to Dr. Kanari to discuss the role of public-private partnerships for achieving universal health coverage. And Dr. Catherine Kanari holds a Bachelor of Medicine and degree from Nairobi University and a Master's in Public Health from the Leeds University. And she does have extensive experience, over 17 years in public, private, and NGO environment in Kenya. And she currently is the Universal Health Coverage Lead at AMREF Health Innovations. And within that, the portfolio includes innovative solutions for healthcare service delivery that leverage emerging technologies to deliver measurable impact within African communities. One thing I thought it was important to mention as a summary, because I won't go through a full bio, you may spend quite a bit of time on that. I just wanted to say there's this focus that she has on partnerships, looking at implementing end-to-end programs in non-communicable diseases, integration into health programming, public-private partnership in primary health care, inclusivity in health service provision for people living with disability, and sexual reproductive health market access approaches. And her work spans across several countries. And with that introduction, I would like to hand over to you, Dr. Kanari.
Thank you, Nick. Really appreciate being on this panel and just giving a few of the insights from the work that we've done and learned from. So when we target or look at universal health coverage, we're looking at the population then accessing quality healthcare services without going through financial hardships. One of the key cogs of universal health coverage is primary healthcare, because we know health begins at the household. And so when we looked at primary healthcare, we saw various gaps within countries, but specifically the work that we did then commence to do was within Kenya. And so we identified one county. The health system in Kenya is devolved. That therefore means that we have 47 counties. Each county takes the responsibility of looking at the health needs of its community where they are. And so we looked at one county, that was Makueni County, and we came together and said, we want to address this challenge of primary healthcare. How do we go about it? How do we co-create a solution that is both innovative, creative, and successful? And so we started by the basics. How much money is allocated to primary healthcare? We did not even have an answer for that, because what we do is we allocate money for health. And so once we were able to delve into the crux of things, we carried out a feasibility study. We were then looking at a public-private partnership that can successfully deliver primary healthcare. And so when you look at a PPP, the spirit of a PPP in Kenya is based on 3 tenets, and across the world, really. We're looking at value for money, you're looking at affordability, and apportioning appropriate risk for both parties. You're also looking at ensuring that the public mandate is delivered through efficiencies from the private ecosystem. Therefore, one of the things we went ahead and did was a feasibility study. It was in collaboration with the county, Philips, and AMREF. And so we looked at the supply and demand side of things. When you look at the supply, what is available in terms of infrastructure for primary healthcare? And we addressed the gaps. We did the assessments and we saw the gaps. And we realized that for you to deliver a concrete primary healthcare system, these are the inputs you need on the health system. So looking at healthcare workers, looking at infrastructure, looking at machines, diagnostics, and looking also at the demand side of things. So on the demand side of things, you can create a good infrastructure and system. But if the people do not then come to seek the care, it's a challenge. If they cannot afford it, it's a challenge. So government here also played a role because the policy of the day was favoring a few things. One of the key things that the county was keen on in addressing in their primary healthcare was maternal and child health. And so the country had a policy where every mother who delivered in a facility, they were able to receive some reimbursements. Secondly, as a country, we've adopted UHC and we have a social health insurance scheme. And so once you're seen in a health facility with this social health insurance scheme, the facility can be reimbursed. So there were revenues to be realized from this system. Where does the private entity come in? The private entity comes in terms of building that infrastructure, in terms of giving the technical assistance necessary for efficiencies in systems. The system was in existence but was not efficient. We had facilities seeing patients, but they were not claiming. Small things like putting computers therein, putting people to then do the claim system so that they can be able to be reimbursed. And then there was the capitation model. So in essence, the priority for the county was maternal and child health. And what were the results that we realized by putting on all these things? One of the key things we also advocated for was enrollment into that National Health Insurance Fund to ensure that patients or the communities are not then going back out of pocket to pay for these services. And so what we realized was, one, that these facilities were able to have an increase of at least 48% in skilled deliveries. They were also having an increase in service utilization. The services were there, but they were not complete. Once we completed the services, they were able to come and utilize the services. We also realized and recognized new revenue streams from the private services. So there was an additional average monthly revenue from the private services, and then from a baseline of 0, because we did not have this before. And so we saw a 400% increase in healthcare revenues. We also saw that as people came to seek their care, in as much as we had focused initially on maternal and child health indicators, we saw the other problems that were in the system. We know that we are now burdened more commonly with non-communicable diseases, which African systems have not traditionally been prepared for. And so there was need to then have optimization of the preventive services. And for this, we relied heavily on the counties and the community health structures to raise awareness, to refer people to the facilities, and the need for early treatment and diagnosis vis-a-vis late presentations. So these are some of the things that we did see. We did experience a few challenges in policy and in then executing the full PPP, because at the time, primary healthcare services are free in Kenya. So there was a need to then ensure that also counties are able to go into a public-private partnership by themselves. Remember, a public-private partnership is a long-term engagement most of the time, and it requires a negotiation of repayment for the private services, because this is a private institution then delivering a public mandate. And therefore, as we are proceeding with the process, those are some of the things that are being tackled at a national level, ensuring that counties can now also engage in PPPs by themselves. Traditionally, it is the ministry and the treasury that go through these processes. So I think in a nutshell, we saw that it is possible, it is feasible, it is affordable to carry out a PPP in primary healthcare and deliver on the same in terms of measurable impact and in terms of ensuring that there's efficiencies brought on by the private entity. Thank you.
Thank you so much, Dr. Kanari, for such a detailed talk. We really appreciate that. Some of you may be aware, in South Africa, we have a little bit of this power cut. So pardon my slight dim look, but I think the show will continue. So I'll now hand over to Dr. Agada to present a case study from Nigeria, which focuses on recent efforts to try and implement universal healthcare in Nigeria. So Dr. Agada, you hold a medical degree from University of Calabria, master's degree in public health and management, also from University of Maiduguri. He's got certificates in improving quality of healthcare from London School, as well as from Harvard University. School of Public Health, and he's currently studying his PhD in implementing health system policy and economics from the University of Nigeria. And over the last 2 years, he's been working with the National Health Insurance Authority in Nigeria, where he leads an effort to develop and implement policies for the agency. With regards to operational guidelines and quality management guidelines for this NHIA effort. So we look forward to hearing from you. Doc, over to you.
Thank you, Nick, for the opportunity to speak this morning. I'm to talk about the progress that Nigeria has made in the area of universal health coverage. The mandatory law, what we call the National Health Insurance Authority Act, was signed into law by the President of the Federal Republic of Nigeria, General Buhari, on May 19, 2022. And this is a very solid move in the direction of UHC for the entire country. Before now, the former NHIS, which is a National Health Insurance Scheme, had operated since 2005. And we had, if you understand the political structure of Nigeria, we have the federal system of government. And so we had implemented that since 2005, but progress towards UHC has been slow. And this is mainly due to the fact that there is decentralization of the health to the three tiers: the local government, the state level, and also the federal level. So they all participate in policies and implementation of policies for health. And so it's been difficult, but with the passage of this new law, it has become mandatory for all Nigerians and legal residents in Nigeria to hold a health insurance policy. So towards that, we have kickstarted the implementation of the Act. We are working towards developing the secondary laws, which is the operational guideline and all other policies. We're currently doing that, and we are trying to ensure that all the things are done and dotted at the right time. We are also collaborating with the state structure set up for health insurance, what we call the state social health insurance agencies in Nigeria. And so that has already taken place. All the states in Nigeria has already set up state social health insurance. That makes 36 plus 1 for the Federal Capital Territory health insurance agencies in Nigeria that are operating as we speak. We are providing coordination, we are providing regulation for the health insurance ecosystem. Nigeria is a resource-poor country, and government definitely cannot take the issues of budget for health entirely. And so that's where health insurance becomes very important as a means of healthcare financing. And so we are developing that, and we are ensuring that we are talking with the state agents, and we're also talking with what we call the health maintenance organizations in Nigeria, who will be playing largely very big role, both in providing technical support to the states and other structures, including acting as a third-party agents, and also looking at the private health insurance space, which will be largely run by them. And so we have all that we're building for now is looking good, especially with the mandatory law. And so we are building the structures, and we are believing that in the next few months, and we will be firmly in place to the final march towards a universal health coverage. It's also important to note that the key reason for the new act, the desire to have this new act has been long as the old act, because wherever you have a social health insurance that is not mandatory, growth and the coverage is slow. So the mandatory nature will make it possible for us to move quickly. Yeah, so we have also at NHIA, as part of the Future Proofing Health, building capacities for data management. And so we have what we call the ENHIA, which we are hoping will be launched very soon, maybe during the Health Insurance Summit in Nigeria, which will come up on 2nd and 3rd of December. And that will provide a whole data platform for the whole ecosystem for health insurance and the whole health system in Nigeria. So we'll be able to collect data in a better way, be more efficient with data, and be able to do things with evidence in Nigeria. We have also partnered in various ways with companies, pharma companies, in what we call the cost sharing aspect of the NHIA Medicine Supply Initiative, where we are making it possible for our enrollees to be able to access innovative medicines that cancer medicines that are before now very expensive and usually almost inaccessible by the average Nigerians. We're making that happen, and for people who are on the scheme, we're able to provide such access for them. So back to you, Nick.
Thank you, Dr. Agade, for that. I think it's a very interesting conversation, which a lot of us will be paying attention to as it evolves. And actually, I would like to also remind those who joined late that please ask your questions as these discussions happen, and we'll field them as we go along. So drop them into the chat and we'll come to a panel discussion where we'll address them. And now I would like to move on to the third case study from Prof. Butaya, who will present an example of the creation of an e-health innovation center at University Mohammed in Rabat, where he currently works. So he's Prof. Butaya, he trained as a Moroccan medical oncologist. He obtained his certification in medical oncology in 2008. Between studying in Rabat and Paris, and he holds a PhD in clinical epidemiology from Rabat, and he currently serves as the manager for the Chemotherapy Day Hospital and co-referent for the informatics system within the Moroccan Institute of National Oncology. And he specializes in treating GI and breast cancers. And he holds his position as a professor of medical oncology at the University Mohammed in Morocco. So over to you, Prof.
Thank you, Nick. First of all, I'm honored to be part of this panel today. My intervention will be about public-private partnership, especially how PPP could help developing countries to shortcut the gap in technologies, especially in health. As you know, in our country, I mean in African countries, we face the same issues in terms of human resources, and we face migration from Africa to North America and Europe, I mean for caregivers. The inadequation between the needs of population and the resources that are allocated by the government, and last but not least, the spatial inequalities within each country. Currently, e-health is defined as the field in the intersection of medical informatics, IT in general, and health systems. This field includes all the health services and information that are delivered through internet and related technologies, such as the health apps, information systems, artificial intelligence, and telemedicine. Worldwide, the COVID pandemic was a real accelerator of e-health. The stakeholders and the practitioners agreed that e-health is essential for the health systems, and several IT projects demonstrated this. Despite well-documented reports on the benefit of e-health and health IT in general, the e-health adoption in our countries is not well adopted, largely due to technological, financial, cultural, and organizational factors. The Future Proofing Index revealed that PPP also is one of the best ways to overcome some of these structural barriers. And let me give you an example coming from Morocco that demonstrates that PPP is very helpful for launching a national initiative in e-health. As you know, Morocco is a North African country and is considered as middle-income country. Morocco faces an epidemiological transition called the double burden, with the coexistence of communicable and non-communicable disease. As developing country, Morocco faces the same the same issues than the other African countries, particularly the limited resources in general, but in particular in health system. The Center of Innovation in e-health, called in French Centre d'Innovation en e-santé, is the fruit of collaboration between a public university, my university, called University Mohammed V of Rabat, which is the main public university in Rabat and one of the most important university in Morocco, and private company called ITESIS, which is an IT company that promotes IT in general and e-health in particular. The first step for these two partners was to work on a white paper with all the parties that are concerned by health in general. And the aim of this paper was to provide relevant and up-to-date information on the situation of e-health in Morocco, to size the opportunities and to meet the challenges of integrating available solutions, to identify the obstacles and challenges hindering e-health promotion in Morocco, and last but not least, to develop a roadmap in order to facilitate rapid and effective implementation of e-health in Morocco and in other North African countries also. In April 2022, the Center of Innovation in e-health was officially launched, and this center issued the report called the White Paper on e-health in Morocco that assessed the national healthcare system and identified the opportunities and challenges for e-health solutions. The white paper was presented in Rabat in the presence of three ministers: the Minister of Health, the Minister of High Education and Scientific Research and Innovation, and the Minister of Digital Transformation and Administrative Reform. It was also an opportunity for these three ministers to sign the sponsorship agreement for the e-health innovation center. Various partners have integrated the center, and this panel of partners agreed that the center will be domiciliated in within the university, and created a board of directors comprising representatives of various ministries, of leading companies in IT, such as Orange, and leading companies in healthcare, such as Acdital and Encorat. Other academics partners from the private and the public sectors joined this consortium, such as the University Mohammed VI of Casablanca, which is a private university, the National School of Public Health, which is a public school of public health, and others companies. Since its creation, this center, in addition to the white paper, has organized numerous conferences and competition for e-health projects. And currently, the center is working on 4 major projects. The first is an university diploma in e-health, with the participation of 3 universities: our university, the University Mohammed V, the University of Casablanca, I mean the University Mohammed VI of Casablanca, and the University of Aix-Marseille in France. The second project is an African forum dedicated to e-health, which is expected in September 2023. The third project is a white paper on health data exchanges. This white paper is currently being written and is expected for April 2033. The last project is a second project competition, which is planned in next May with the participation of major companies in IT, local companies and international companies. Finally, the PPP was the best way to unite the different partners and to develop a global health initiative. Thank you for your attention.
Thank you again, Prof. Butaya, for such a very concrete and sort of clear example there that people can learn from. And that sort of brings us to the end of the 3 talks, and we prepare now for a panel discussion and a Q&A from the audience. And then maybe to sort of lead us into that, maybe it's useful for me if I can sort of reframe, some of the key points that came from the 3 talks that we just had. So if I start from the beginning, we heard from Dr. Kanari, and so she gave a successful PP example between AMREF, Makueni County, and Philips, and this PPP was revolutionizing primary care in Kenya and relying on respective strengths of the different partners to guarantee that the supply and the demand in terms of primary care are supported for the population. And I think from Dr. Agada, you took us through the way the Nigerian National Health Insurance Authority, which will make health insurance in itself mandatory across the country. And this will be the single most important step in achieving universal healthcare on the continent in the next coming years. And here again, we see the role of private sector is going to be determinant when it comes to how the NHIA will work with the private hospitals and facilities to ease the access to care. And you sort of mentioned in the end around cost sharing schemes, that are also being discussed. So we also look so forward to see how that can eventually result in accessing medicines. And lastly, Prof. Butaya, you took us through a concrete example of a PPP that led to the creation of an e-health innovation in Morocco, first of its kind, I assume, upon recent recommendations stemming from the work conducted under this PPP. The Moroccan government is now announcing that it will launch an integrated e-health system across the country. So I think this really gives us a very good broad context of where we are now, and it may be useful if I first give you an opportunity to maybe ask your fellow panelists a question that may be of interest to you. And since Dr. Kanari, you've been there, you've spoken first, would you like to go first?
Sure, Nick. Thank you. You seem very serious today, so I'll go fast softly. So, Dr. Agada, I'll give a few comments or questions. Kenya has tried to go the mandatory way for National Health Insurance Fund without much success. When we look at the numbers, we only have around 18 to 20% people who are employed and are actively contributing to the National Health Insurance Fund, which is your social health insurance fund. And so the challenge becomes the more than 80% who are in the informal sector and who then need to pay for this health insurance fund so that we have a good base for paying for services. But also, how do you then ensure that they stay adherent to this when you make it mandatory? So maybe just to hear what the penetration looks like now and what then the penetration might look like when it becomes mandatory, and maybe some systems that you have put in place to ensure that people keep paying. At Prof. Butayeb, my question would be, what have you learned so far? I know it's very early in integration this e-health, and what have been the main challenges? Because one of the key things we see is also as a country or as a region is that acceptance of ensuring that there's that integration. So having many parallel systems instead of consolidating into one, so leading to a few to data collected in various ways. So we have a Kenya Health Information System, but at the health facility level and let's say at the community level, we are then not yet at the final pin to then do one system that can feed into the Kenya Health Information System. So those are my 2 comments. Thank you.
Would you like to go for it, Dr. Gada?
Yeah, thank you, Nick. So I don't have so much to say. It's been interesting. Professor and Catherine for the comments. I mean, the presentation so far has been excellent in my view. The PPP in Kenya and what's been done in Morocco. Right now, I don't have comment except to say that I've enjoyed the presentation so far. Thank you.
Great. Over to you, Dr.
Thank you, Dr. Canary, for your very interesting talk and also for your question. We have a lot of similarities between Morocco, Kenya, and Nigeria, and we have many challenges for the e-health implementation in Morocco. The first barrier is maybe the rules, because the Moroccan rules about data collection are very severe, and we don't know still now who is the owner of the data. I mean, when you have a data collection in one hospital, you should ask for a lot of authorization in order to analyze the data and to publish it, for example. Till now, we are waiting for a guideline that will be very useful for the scientists and the academics in order to get the data from the health information system, to analyze it and to publish strong local scientific reports. The second issue is that the Moroccan insurance system is very heterogeneous. We have 3 categories. The first categories are a category of citizens have a public insurance. The second one have an assistance system, and the third one is not till now covered. We expect universal health coverage for next year, which means that you have the private sector, which is very strong in Morocco. In general, all the clinics and private hospitals have their own information system. The public centers and hospitals are also well equipped, but the primary care system is till now not well equipped, not well connected. We face also the third problem that you mentioned in your intervention, which is the interoperability between the different systems, because we are working in Morocco on a global network with multiple systems that are connected between them and that collect all the data from the primary care system to the university hospital or to the major private sector hospitals, but still now it's not operational. Thank you.
Thank you so much for that. And maybe I come back to Dr. Agada to just address Dr. Canari's question she asked earlier there.
Thank you very much, Nick. There were comments around ensuring continuous payment of premium. So that's been one of the things that we're looking at. How do you get people to continue to pay? So you need to look at the public sector of the economy, and then the private sector, the informal sector, and the formal sector. So the formal sector collection of premium is a lot easier because we tie it to salaries and all that. The informal sector, we're looking at a lot of things. Some might not be very pleasant. Some will be very pleasant. Like if you want to do government businesses and all that, you have to have a health insurance policy. You want to apply for maybe international passport. You want to go to the bank and all that. So we're looking at a lot of things. The law, we look at the law and what level of empowerment we have. But as we speak, we already have what we call the group, individual, and family social health insurance schemes that makes it possible for private sector and informal sector people to be able to easily enroll. Apart from that, we also have the state social health insurance that have a lot of products for the people in the informal sector. And of course, once it is mandatory, the civil servants at the level of the state and local government will also be enrolled. So we're looking at all that, and that speaks to why we need to urgently put in place a good and robust ICT structure, like I was trying to say earlier, to be able to capture all this data. We in Nigeria, we are building what we call the national identification numbers, which means we can also begin to tie the health insurance to your NIM number or national identification number. We are doing all that, and I'm sure that in the near future. But for me, the more critical issue is to prove to the people that health insurance is working, and let people be able to go to the hospital, and as they're in the hospital, they get the services. Why should I pay if I'm not going to get the services? So that's important. And the other leg of the comment is to do with the vulnerable group, which is very key, because if you're talking of a UHC, you must also look at the underserved population. So we're looking at building structures in that area. We already have the report from the Nigerian Land Center Commission that says 83 million Nigerians may not be able to pay their premium. And so we are engaging the government. We've done a lot in this area. We're engaging government, we're engaging the private sector groups, and we're trying to raise funds in building a structure that will be able to mobilize funds for the vulnerable group. We already have in place what we call the Basic Healthcare Provision Fund. The Basic Healthcare Provision Fund is a product of the National Health Act of 2014, which compulsorily makes it that government should set aside not less than 1% of the incomes coming to the government to be used for paying for the healthcare of Nigerians, and we have already operationalized that. So we have built that system where we pass the fund onto the state social health insurance agencies to enroll vulnerable peoples at the level of the state. So that's ongoing. That is quite sustainable, and the National Assembly is looking at even increasing that beyond, because what the act, the NHA Act of 2014 says is not less than 10%, not less than 1%. And the National Assembly is looking at trying to increase that. That will bring more money into that fund. Like I said, a lot of innovation have to come into this. We need to find other ways of mobilizing funds to be able to pull them together and pay for that particular group. Because I agree with Catherine, that will be key to what progress we'll be able to make. How do we pay for the people who cannot pay for themselves? Thank you.
Yeah.
Back to you, Nick.
Thank you for that, Dr. Gada. And I'm aware that we're left with 15 minutes. I'd like to ask these questions, and maybe we can have brief answers to each, and so we can cover as many questions that are coming in. So maybe I come to you, Prof. Butayab. So, you presented a very interesting example of a PPP supporting e-health in Morocco. Based on your experience, on your experience and what you heard now from Dr. Gada, how do you think the African continent can best harness the potential of e-health to advance universal healthcare?
Thank you, Nick, for your question. As you know, e-health include a large panel of solutions such as m-health, telemedicine, artificial intelligence, and others. Telemedicine is very important for our countries because, as I mentioned in my intervention, we have very important issue of human resources in number and in geographical repartition. At the country level, the public health policy can't be designed, financed, and monitored without a strong analysis of the data. It's really mandatory to get the data. And the only way to get the data is a network of information, as Dr. Canary mentioned in her question. It means that we should have a very strong information systems that include the primary care system, the private sector, and the public hospitals. So it's absolutely mandatory to develop a smart network of systems that are interoperable between them, and to have the law that allow to get the data and to analyze it. So we in Morocco we are working on this point in particular. The second point that is, in my opinion, important is that the hospital systems in general, at the level of the hospitals, is also an excellent tools for cost reduction and quality care. A lot of multidisciplinary meetings are now done online. And last but not least, mHealth applications are not very costful and are very practical and very efficient for patient education and prevention programs. Thank you.
Thank you for that. Thank you for that. And over to you, Dr. Canary. So this one is a quick one. So based on what you have experienced, if you had to restart, what would you change or do differently?
Thank you, Nick. So for me, I think we have a challenge generally globally. When we get health technocrats in a room, we forget the financial counterparts and vice versa. So what I would do differently is also lobby for the financial counterparts to always be in the room as we are creating this. PPPs. And when I say finance counterparts, I also mean the political elite, because as I mentioned, that for us, we are a devolved system. So the budget holder is the county. If we don't get them on board from the get-go, because one of the key challenges we had was within the feasibility study was the policy bit. So we need them to lobby for policy change. And that's what I would change first. I would really look at the policy outputs instead of then looking at the other end. However, within that, we have learned that in this co-creation, we always then need that political buy-in for the same, to buy into the vision. but also I would let data speak for itself. As we're hearing from my colleagues Butayeb and Agada, data is key in informing those decisions. It's key in the policy changes. So if data is saying that PPPs can assist us with healthcare, especially at the primary healthcare level or at whatever the level, then it is more convincing. If it's showing us that we can create impact by these PPP interventions, then you can have a lot of buy-in from the political and the financiers of the health budget. Thank you.
Thank you for that. And I want to come back to you, Dr. Agada, and just to say, in short, how have you used data at your disposal to inform the content of the law you presented? Would you have been able to make better decisions if the health system was digitalized?
Yeah, so thank you very much, Nick. Data is very important. Data, like I said right from the outset, when the law was passed in 1999, we knew we were going to run into problems. Because a health insurance system, a social health insurance system that is not mandatory will be very slow to implement, looking at the culture of the people and all that. So it did help us to drive forward. We're looking at data and we're looking at the level of coverage. We were sure we were not going to make the kind of movement towards UAC would have wanted if we don't have a mandatory law. That's behind us now. It's in operationalizing it we're talking about. So for data, yeah, so now we need a lot of automation to be able to quickly enroll people, give people access to be able to enroll from wherever they are, at home, at work. We need data to be able to buy strategically, to purchase the health service and products strategically. We need to buy the right products for the people, what is more important to them, through exit interview, through collection of data, through other ways. We need to make the health system, health safety and other quality of care. Data is important wherever you look at it. If we are thinking of modifying the provider payment system methods in the future to be able to do something that is more compact, we'll be looking at data. So wherever you look at is data. And like I said earlier, we are aware of this and we're building the system to be able to get this challenge to be with this challenge. Thank you, Nick.
Thank you for that. So I want to come to you, Prof. Butayeb. So there's a question here from South Africa. It says, can you share a specific example of how you ensure that PPPs are sustainable with limited resources?
Oh, very interesting question. In our model, we have a lot of private partners that offer two kinds of supports. The first one is a technological support. They have a lot of engineers, for example, and they help the developers, the young developers, to have for free a technological support to develop, for example, apps or local information systems or a platform of telemedicine. The second way is that we offer small amounts, I mean, not a lot of money, but enough to start. It's a kind of incubator. We didn't launch till now a real incubator because it's really complicated to launch. So we are working on that. It's a project that is expected for next year. And each developer should have his own business model. I mean, the product should have a commercial value for an hospital or for an insurance. So each developer develop his own business model and look for an additional financial support from banks, for example. There is many program for young developers in Morocco, supported by private equity funds and public and private banks.
Thank you. Thank you for that. And I'll come to you, Dr. Kanari. It's a question, how are you linking financial access to healthcare services and improvement of quality of care through PPPs and innovation? Quality of care seems to be usually left behind in UHC efforts.
Thank you for the question. Yes, quality of care has been quite the debate. And for us, what we then did in terms of co-creation, we still went to the community. What does the community want to see in a health facility? Why do I leave my home and go 10 kilometers away to another facility? So when we were looking at the elements of primary healthcare that were necessary, we went first to the community, and then we also went to co-create with the health leaders as well as the politicians. And so one of the key things they said was basically we need a facility where if I am pregnant, I do not need to go do my antenatal tests in another facility. And this was the challenge, especially in public health facilities. Yes, you might find the healthcare workers, but there are some key elements that are missing. And this is where the private element came in by helping ensure that the infrastructure was sorted. This is also where the county came in and said, if this is the priority of my community, then I will put up some money for this. I will ensure I hire for this, and I will do some infrastructure that is necessary to facilitate this. So when we look at it, both elements came in. The public element, where the county is then able to prioritize against the needs of the community, and also the community needs. So the private sector is then enabling the public sector to deliver on its mandate and improving that quality. One of the other things we saw was basic things like small basic ultrasound, really improving the perception of the community around public health facilities and also the quality of care. So this was it was a beginning, but we are also seeing that across for Kenya, generally right now, there's a heavy push towards primary healthcare and getting it right. And one of the key gaps that has been prioritized everywhere is the infrastructure. Basic diagnostics, basic treatment. The other infrastructure elements are human resources for health. So I hope I've answered the question. Thank you.
Thank you for that. As we come closer to the end now, I would like to give you an opportunity in 1 minute to just maybe summarize to say what is needed to secure the financial sustainability of African healthcare systems based on what you've heard today. So I want to start with you, Prof. Butayev. What's needed to secure the financial sustainability of healthcare systems today? In 1 minute.
Well, in 1 minute, I think that it's a really interesting point. Our three countries have a lot of similarities. We are all working on the universal health coverage, but we should find financial solution for the sustainability of universal health coverage. We should think about the health taxes. We should tax maybe tobacco and alcohol in order, and we know that there is an increased use of tobacco consumption in our countries. And maybe the second point is we should work together in African network in order to share our solutions. It will be for sure very important for cost reduction. Thank you.
Thank you. And over to you, Dr. Amanda.
Thank you, Nick. There's a question on UHC's major challenge. It was noted to do with leaders, so I will round up with that, answering that question. So we've got a lot of challenges with leadership and how they view health, and I think it's a narrative that we have to bring to the table to be able to address. We started that in Nigeria. The reason that the key point there being that the president has realized the importance of health insurance and have made it mandatory for our country. That's the biggest political will we can get. Recently, we're at Chatham House in the UK with the DG of NHIA addressing 3 governors who came from the states of Lagos, Nasarawa, and Gombe, and they all were able to give their support. We'll be engaging the political leaders. We have no other ways. They are very key to the march towards the UHC, and I think it's key that we'll continue to provide a forum. The luck we have in Nigeria is we have what we call the Nigerian Governors Forum, which we are also having the opportunity to engage all the governors through that forum. Thank you.
Thank you. And Dr. Kanari?
So for me, key is pushing for increased domestic resource allocation for primary healthcare and UHC, building on the community systems that are already in existence, optimizing prevention across the diseases, especially for non-communicable diseases, looking at how we can then catch them early. It saves the health system a lot of costs when we do the prevention instead of doing curative. And lastly, just to get that political alignment across Africa for prioritizing UHC and primary healthcare, ensuring that we then stick to our commitments when it comes to increasing resource allocation to health services. Thank you.
Thank you so much. And we've come to the top of the hour, so I would like to really take this opportunity to firstly thank the audience for engaging in this conversation. And thank you again to the panelists for really bringing the content and sharing these examples. And hopefully we can start learning, and we continue this forum to really share these learnings and cases so we can see where we can replicate them. And with that, I'd like to close and say we do need better benchmarks to improve the quality of lives for our patients and our healthcare systems. And with that, I'd like to close and have a good afternoon, good morning, or good evening, wherever you are in the world. Goodbye.